I now call upon Dr. Mahesh. He'll be talking to us on monitoring OCT and OCT angiography in DME and AMD.
Thank you, Dr. Shane. This is a massive topic, in fact, OCT and OCTA for DME and AMD. So I thought this is a general ophthalmology crowd. We will just go through some of the findings and some mistakes that we do while treating DME and AMD with OCT. So my first message is, don't treat any patient based on central macular thickness or central subfoveal thickness. And especially if the clarity is not good. There are so many biomarkers or findings in OCT that will guide you. Like in field, visual field, Humphrey field, the glaucoma surgeons say that don't look at the grayscale and treat. So it's exactly same, don't look at that map and treat, because there could be a lot of artifacts. That is message one. Number two, when you do an OCT, take all the sections and see. Do not forget which section is given in that. So all the sections you have to see. So finding may be little away from the central area, especially in AMD. So you have to sit with the machine and scroll little up and down and see the findings. So these are the 2 points that I want to make. So in DME, there are different types of findings: cystoid edema, spongiform edema, and serous detachment. Each one has little importance. I will come to that. And I will show some of the cases of biomarkers. So the classification is center non-involving DME. These sort of cases, we always try to give laser if there are leaking microaneurysms. So this is a center non-involving, that you can see the central thickness is okay, it is just next to that. So the standard treatment is focal laser. Now spongiform edema, this is sponge-like edema. In fact, it is present in 88% of cases. And this central macular thickness is important in the follow-up, but don't treat just based on this. And this is cystoid edema. This arrow mark shows cystoid edema. And this is serous macular detachment. And in fact, serous macular detachment, serous subfoveal detachment, SFD, or whatever you can call, they respond well to anti-VEGF injection. The visual outcome will be better. So that is one thing. And if there are, this is another important thing. I have seen n number of cases with on treatment for injection when there is a taut posterior hyaloid or there is a ERM-like picture, and that will not respond to your injections, how much of injections you give. That is important. So that has to be specifically looked for. And then you have to look for the hard exudate. If there is a hard exudate clump like this in the left side, the visual outcome may not be very good, and that has to be done. So, and another thing is, if the vision is out of proportion to the clinical findings, you may think about ischemic macula. Here is the use for OCTA, and OCTA shows that irregular foveolovascular zone that is important in treating. The outcome may be little bad. Though another important thing is disorganized retinal inner layers. If you see which is a better eye, it doesn't, left one looks better, but in fact the left eye, the inner retinal layers are not at all visible, while in the right side you can see all the ganglion cell, GCL, IPL layer, or everything. So in fact the right eye has a better prognosis. Like that you have to look for the ELM and outer ellipsoid line. If that is also intact, outcome is better. So these are some of the findings. And then when there is a lot of hard exudate, like the hyperreflective dots inside a cyst or subretinal space, there is a chance of clumping after your injection. So don't treat aggressively, treat slowly. Like this, it is pre-treatment, lot of hyperreflective dots, it became clumped in the center. So that is an ellipsoid and ELM disruption. It gives poor prognosis. And this is another case where octa is useful in DME. Patient had nephropathy, I couldn't do any angiogram, dye angiogram, but definitely the octa shows. So this is one of the usefulness of octa in DME. Now coming to, so DME, never treat DME based on central macular thickness, and look for biomarkers and modify your treatment. So that is all about DME, OCT, OCT and DME. Now coming to AMD, I will show some cases. This case, everyone knows this is a AMD, and in the OCT, you have to look at the different sections. if you see only the central section, there is some hyperreflective area just in front of the ellipsoid line. But in the lower sections, you can see that the feature suggestive of classic or choroidal neovascular membrane. And OCTA is showing a nice network there. And post-treatment, you have to follow up section by section in the post-treatment and modify your treatment. Don't just look at one section. So this is post-treatment. So OCT and OCTA both are very useful in following up. And OCTA shows that regression after 2 or 3 injections. So this both are useful in the follow-up of wet AMD. So this is another case. If you see, this is called double layer sign. There is that gap, hyperreflective double layer sign, and angiogram shows mild leakage somewhere. Once upon a time, we used to call it late leakage of undetermined source. After treatment, this was treated some time back with photodynamic therapy and intraocular injection. It has become dry. So the follow-up of treatment, you have to look at each sections of that OCT and see whether there is any activity in any place, like early intraretinal edema or hyperreflective dots, etc. This is another case. It looks, there was a teardrop sign-like picture, and there is fluid. These sort of cases, our differential diagnosis is atypical CSCR or pachychoroid disease like PCN. Here in OCTA, you can see a network in avascular slab, so that means that there is some PCN. So the difference is, this may work, you can go for aflibercept or some anti-VEGF injection. This is another one. This is a case of subfoveal polyp, in fact. One eye, left eye already has a scar, right eye has a thumb-shaped PED, and it was treated initially with just, I think, one of these anti-VEGF injections. There was no response, and this is the ICG showing a bunch of polyps in the center. And in fact, OCTA, almost similar findings are seen as ICG. So OCTA sometimes is as good as ICG in identifying some of the polyps. And following full fluence through PDT with injection, the patient gradually settled and is doing well. So this is post-treatment. Post-PDT, that polyp has regressed to, this is left one is pre and right one is post. So this OCTA and OCT are very useful in the follow-up. Over. Okay. So this is a RAP case. 1 minute is sir. Right. This is a trapezoid PED with intraretinal edema, classic finding of a RAP with a trapdoor sign or erosion. And that is the yellow arrow shows the erosion. And angiogram shows a hyperreflective dot in the center of the PED. And post-treatment, you can monitor the findings with OCT. So this is some pre-treatment and post-treatment findings. So these are all OCT biomarkers that you have to look for specifically in a case of AMD. All these, not only central macular thickness. Now a lot of people are treating with just central macular thickness with injections. And there are a lot of, that is why I wanted to highlight these findings. When you look for the one of these findings and then follow up with the same way, you cannot miss anything. So this is another PED, a lot of variations of PED are there, and each one has a diagnostic implication, I mean treatment management implication. So that is another thing. And OCTA has helped us. These are all different types of networks seen in OCTA, and now we are learning more and more about OCTA in the, and we have identified, as Shane showed, silent network without any fluid. OCTA is identifying silent network like this, which will also tell you that the patient is likely to develop wet AMD. So these are all different patterns seen in OCTA. So, and post-treatment, OCTA is a very useful tool to follow up the AMD cases. And this is another one, type 2 CNVM, where there is a dense network here. So this is post-treatment. You can see pre-treatment and post-treatment in monitoring. So both these things are very useful. This is another RAP, and pre-treatment and post-treatment, how that network has reduced and become mature vessels. So these are all some of the findings. So take-home message, invasive dye angiography can be replaced to a great extent by OCT, OCTA combination. But you should spend some time with the machine looking at the sections and biomarkers. Single printout treatment is not advisable. Thank you for the kind attention.
Thank you, Dr. Mahesh, for that lucid talk. Just a quick question. How do you incorporate OCTA in your follow-up schedule for AMD? Do you do it at every visit after looking at the OCT, or is it mandatory you do the OCT and the OCTA for every follow-up visit?
Yeah, actually in our hospital, the fellows are doing, not technician. So we have given a protocol like if it is wet AMD or PCV, we do multimodal imaging in the initial visit, and the follow-up is with OCT, OCTA. And they will look through the same sections. That is one of the advantages. If the technician may miss some areas. So we all follow-up OCT, OCTA we are doing. This is our pattern.
That's a very strong and robust practice. Thank you, Dr.